Akshita from India. Akshita from India. Thank you so much for joining us. I see Zinira from India. Zinira from India. Thank you for joining us. I see Sandhya from India. Sandhya from India. Thank you so much for joining us. Um, I see Sheikh Afrin. Okay. Okay. We're so excited to have you join us also, Sheikh. Thank you so much. Thank you so much. Again, I'm sorry if I'm mispronouncing the names. Pardon me, please. I see
No.
okay. Am I audible now? Please, I need someone to confirm I'm audible.
Yeah, you are now back. Yeah, your voice. We lost your voice for a short while.
Am I audible now? I think there was like a glitch in the network. Thank you.
Thank you.
Thank, thank you so much. Thank you so much. I also see Aisha from United Arab Emirates. Welcome, Aisha. I see Hamed all the way from Iran. Hamed from Iran. Welcome, Ahmed. We are really grateful to have you join us. All the amazing people that have joined us today. We're really, really grateful. We have about 2 minutes now to the start of the session. And like I said earlier, I am very certain that at the end of today's session, you would be indeed grateful that you did attend the session. Thank you so much for joining us. I see Mandaji. Okay. Okay, Mandaji, very excited about the webinar. We're excited to have you too, Mandaji. Thank you so much for joining us. I see Assalamualaikum from India. Sorry again if I mispronounced that. I'm sure I did mispronounce that. Pardon me. Pardon me. Thank you everyone for joining us. I see Gibson Firi all the way from Zambia. Welcome, Gibson. Thank you so much for joining us. We're really, really grateful to have you join us. Okay, we're going to be moving right now into the session proper. And of course, we'll be beginning with the introduction, and we'll be stating some few house keeping rules to ensure that we have a very, very smooth experience for this webinar today. Thank you so much once again, everyone, for joining us. Okay. So I'll start with introducing myself. Of course, I didn't do that earlier. My name is Destiny Elogusa Ale, and I am privileged to be the founder of Pharmacogenomics, one of the collaborating organizations that's bringing you this very amazing webinar series for the year 2025. And of course, I'm going to be your moderator for today's session. And I'm really excited because I know that I have amazing persons in this room who are filled with energy to learn about pharmacogenomics and precision medicine. Of course, what we thought of when we thought of creating or bringing about this webinar series was to promote pharmacogenomics education, to continue to bridge the gap that we have in terms of education, especially in Africa and in low middle income countries of the world. And of course, we're going to be having a session that's going to be comprised of the discussion, that's the presentation by the guest speaker, and then we're going to be having the Q&A session where you are going to be given the chance to ask the questions that you have about pharmacogenomics and about specifically, most importantly, the things that we're going to be talking about today. Thank you so much. We understand that pharmacogenomics is playing a huge role in healthcare currently, and in fact, this role is going to increase as we continue, as we progress into the future. Precision medicine initiative is becoming the order of the day, and the more of the things that we do in our clinics are revolving around precision, being precise with dealing with the patients. And so I would want to also mention the rest of our organizations. I did mention that Pharmagenosphere is one of the collaborating organizations for these amazing sessions that we're having. We also have some very, very, very amazing organizations. Like we can see on the screen now, we have Medodrix. Medodrix is an organization that's based in India, and they promote and help to see to the fact that pharmacogenomics and pharmacy education is promoted worldwide. And then we'll have the other organization, Transcend Psych Consulting. Transcend Psych Consulting is an organization in Pakistan, that's based in Pakistan, and it's also an organization that's collaborating in this webinar series. And then we'll have the Pharmacy Graduates of Pakistan, Pharmacy Graduates Association of Pakistan, as the fourth organization collaborating to bring this amazing session to you. Thank you so much. Thank you so much. We would also like to recognize our supporting organizations. We have some organizations who have been very supportive in terms of helping us to reach a wider audience. We have organizations like the Pharmaceutical Society of Nigeria, Young Pharmacists Group, Edo State Chapter. We have RX Doctor, which is based in India, Pharma Incubation Hub. We have the Pharmaceutical Association of Nigeria, National. We also have the Pharmaceutical Association of Nigeria, PANS, University of Benin chapter. We also have the Society for Interprofessional Practice, CPEP, based in Nigeria. And of course, we have 24 Genomics, an organization based in Kenya. And so, amazing, amazing participants. Like I mentioned earlier, we're going to be having some housekeeping rules. And the first of this would be to ensure that at any time during the presentation, we have our mics muted so that we reduce as much as possible the background noise that we get, so as to enjoy and make the session a very smooth one. And then you can use the chat box at any point in time. You have any challenges with anything, you are very, very free to use the chat box to ensure that we have a very smooth room. Thank you so much. And then if you do have any questions as well, you can also drop them in the chat box. And during the presentation, of course, our speaker would let us know if we could ask questions during the presentation, or if that should be specifically to the end of the session. And then another thing would be for technical glitches. If you have any issues, you can drop any of those issues on the chat box, or if you are finding difficulty to join after leaving or something, you could use the WhatsApp room to also reach out to us. Okay, and so we would move into the session for today now. Of course, we know that today's session is about introducing pharmacogenomics, and the way we planned the series is such that by the end of the series, we should have a complete package of what pharmacogenomics is all about. We should have a deep knowledge of what pharmacogenomics is about. So each of the sessions for the entire series is crafted in such a way that we get this robust knowledge of pharmacogenomics. And of course, it is very important that we begin with an introduction to pharmacogenomics. Yes, we understand that a lot of us know so much about pharmacogenomics, but for some of us who may not know much about pharmacogenomics, we thought it wise to start with an introductory session to pharmacogenomics. And that is what this session is about. I enjoin you to ensure that you remain very active and engage the session. You can drop your reactions to messages. You can clap. You can drop the fire emojis. Thank you so much. All right. And just to also mention that to be able to qualify for getting certificates, we will use
Sorry, Destiny, I lost your voice. I can't hear you anymore.
expected to meet at least 70%, of the attendance for each of the sessions. So attendance will be taken here on Google Meet. So ensure to be present to take attendance, and that will be done automatically, by the way, because we have a way to do that. Thank you so much. And then but diving deeper into the session for today, of course, like I mentioned, the session today is Introduction to Pharmacogenomics. And we have a very, very amazing speaker to do justice to this. The person of Dr. Zaina Al-Mahari is going to be our guest speaker for today. And I will go straight now to reading the biography of our speaker. Dr. Zaina is an assistant professor of genetics at in genomics into teaching and research. A distinguished pharmacogenomics scientist, she holds a PhD in pharmacogenomics from the United Arab Emirates University, UAE, and has contributed significantly to uncovering rare and novel pharmacogenomics variants in the Arab population. Her research is widely recognized with multiple publications in prestigious international journals. Dr. Zaina has received advanced training in medical education through the Harvard Medical School's teaching in medicine program, enhancing her innovative approach to precision medicine education. She is an active member of the International Pharmacogenomic Consortia, including CPEC and PharmVar, and holds editorial roles in scientific journals. Additionally, she leads the IVPN Personalized Medicine Initiative focused on expanding pharmacogenomics education and its clinical implementation, particularly in the Middle East. And so, without any further ado, we would be welcoming now with a round of see the emojis today's session, the person of Dr. Zaina Al-Mahiri. Thank you so much, Dr. Zaina, and the floor is yours. Thank you so much.
Thank you, Destiny, for this kind introduction and for the generous introduction, and also all the emojis I'm receiving from this kind audience. So hi all, Zaina Mahiri, as Destiny have told you. I would like to share my screen. Is it possible that I share my screen? Destiny, I'm not hearing you, but I suppose that I am.
Yeah, absolutely. You can share your screen.
Okay. So now you can see my screen.
Okay.
Hello.
It's okay. Yes, it's coming up now. Yes, we can see your screen now.
Okay, great. I'm happy to be here with you today. I would like first to thank you, Destiny, for the kind invitation. To thank for this also invitation, and for all the organizers who gave me this chance to be here with you to introduce my humble knowledge in pharmacogenomics about and introduce this topic, that beloved topic to my heart, to a large audience from around the globe. So, should I start now? Regarding the questions, I believe that leaving them until the end, but please remember to write them down in the QA or in the chat box, and I'll get back to them as soon as we reach into this point. Okay? So,
Fantastic. That's absolutely.
So hopefully by the end of this presentation, you will be able to be defining pharmacogenomic and explaining its role in precision medicine. You will be able to analyze the main historical milestones in pharmacogenomics and differentiate the key pharmacogenomic concepts and terms. And also you'll be able to evaluate the important resources in pharmacogenomics and how to use these resources to be able to apply this knowledge in clinical scenarios. So to start with, in 2015, Lodge and colleagues have asked a question: how effective are common medications? And unfortunately, by analyzing a group of very used common medications, it was found that almost most of the medications that are very frequently used lie in between the medium to small effect on the required effectiveness range. Also, in 2022, it has been reported that adverse reactions is still an issue with global impact. Adverse reactions are estimated to be between the fourth and sixth most common cause of death worldwide, taking their place among other prevalent causes of mortality like heart diseases, cancer, stroke. So it is a global issue impacting healthcare. And that's why precision medicine comes into its role in dealing with these two problems. Precision medicine tries to optimize drug efficacy and minimize adverse drug reactions. So, but as we all know, drug response is not dedicated by only one factor. It's dedicated by our different lifestyles, by disease characteristics, by the other diseases that we are like suffering from at the same time with the main disease we are being treated for, the environmental effect, our age, weight, BMI, different factors, and also by our genes. And as we know, every human being shares 99.9% of their DNA with other humans. But this 0.1% that is unique to you and me is all make the differences between all humans in height, eye color, skin tone, mental health, personality differences, our health, our disease status, but also it dictates our drug responses. So here comes pharmacogenetics and pharmacogenomics, which is the science that studies this variation in DNA sequences as related to drug response. So the aim of pharmacogenomics and pharmacogenetics is to prescribe the right drug to the right patient at the right time, which is the core of precision medicine. In pharmacogenomics and pharmacogenetics, we can define it as the study of variation in DNA sequences that encode proteins active in drug, pharmacokinetic or pharmacodynamic pathways. And it is important here to remind you with the central dogma in molecular biology, where any DNA should be transcribed into messenger RNA, and messenger RNA will be translated into protein. So any differences or variations in the DNA will affect the end product of this variation, which is the protein. And hence, if this protein is active in pharmacokinetic or pharmacodynamic pathway, that alteration will affect that or the other pathway. So the study of genetic material or DNA variants related to drug response that affect either pharmacokinetics, which means, as a reminder and refresher of our basic pharmacology knowledge, pharmacokinetics include absorption, distribution, metabolism, and excretion, or in ADME, not as known as ADME genes, and or ADME proteins, and pharmacodynamics, which impact the drug targets, receptors, ion channels. So by this brief introduction to the word pharmacogenetics, let's go back into the historical background behind the science. Some literature likes to date back pharmacogenetics to Pythagoras in 510 BC with his first observations on fava bean intolerance. And also in 1909, Archibald Garrett has also identified the fact that medicinal doses vary in effectiveness among individuals. In 1932, Larry Snyder's work have revealed that the inability to taste phenylethylurea can be explained by genetic recessive mutations. Later on, some studies have connected or found the basis of different drug reactions to succinylcholine, to primaquine, and to isoniazide to be related to hereditary deficiencies in cholinesterase, G6PD, and N-acetyltransferase. However, until that point, the word pharmacogenetic was not recognized until the year 1959, when Frederick Vogel was first to coin the term pharmacogenetics as linking between the science of genetics and the science of pharmacology. After that, multiple twin studies on drug metabolism have characterized CYP2D6 metabolism polymorphism, variations as a cause for metabolism variability between. Later on, polymerase chain reaction, PCR, has emerged, and that was as late as the 1980s when the PCR was invented, and at the same time it was accompanied by a lot of like finding out the molecular basis of a lot of genes. And one of the earliest genes that has been characterized is CYP2D6, and how this gene is polymorphic and how these differences will affect the enzyme produced by this. So this is a summary of the main milestones in pharmacogenetics, the main findings that pave the way for the understanding of gene-drug interactions. But we can't ignore that 2003 has witnessed a huge milestone in the whole field of genetics, including pharmacogenetics. It was the year when the Human Genome Project has been completed. It was one of the most significant scientific endeavors in the history. It fundamentally transformed our understanding of human biology and accelerated scientific progress, so laying down the groundwork for future innovation and medicine. So I'm still saying pharmacogenetics and pharmacogenomics. What is the difference between the two words? While they are used interchangeably, pharmacogenetics refers to the single gene-drug interaction, while pharmacogenomics is more about genome. So the relation between the two words is a relation between a gene and genome, where gene is the unit of the whole. So now we are more into pharmacogenomics because we have the technical abilities that allow us to study all the genes and their interactions and their effect on drug response. So pharmacogenomics aims to increase patient safety and drug efficacy by tailoring drug treatment to an individual's genetic profile. So by this, we can move from one size fits all medicine that has been used for a long time since the start of medical knowledge and medical practice, when the medicine is given at one dose, the optimal dose or the average dose, and then the patient might suffer from adverse effect or see no benefit, and also, of course, patients will see benefit and will not be suffering from adverse effects. We are moving from this into certified medicine and precision medicine, in which all the factors that we know affect the drug response, including mainly genetic factors, should be included in order to ensure delivery of the right intervention to the right patient at the right time. So what are the main concepts and definitions in pharmacogenomics? And I'm going to spend some time in this part because the role of, or the goal of my lecture is to lay the ground for the for the following lectures in this series. So I hope you don't find these concepts very boring, and if you know them, it's good, but if you don't know them, you can't complete and you can't be understanding the next lectures without these. So I hope you find them useful. So to start with, what is a pharmacogene? A pharmacogene is a gene that has one of the following roles. Because indeed, for a long time and until now, most of people think about pharmacogenomics about only metabolizing enzymes, and they only focus on CYP enzymes, CYP2D6, CYP2C19, C9, and this is what they understand pharmacogenetics is about. But pharmacogene is any gene that has role and is associated with drug mechanism of action, such as VCORC1, which encodes an enzyme target by warfarin, or involved in metabolic transformation of drug, as exemplified by CYP2D6, which encodes an enzyme responsible for the metabolism of substantial proportion of medications, and also genes that are active in transportation of drugs, like ABCB1, which encodes transporter protein, pivotal in moving various medications and endogenous compounds. So, in general, any gene that encodes a protein active in drugs, pharmacokinetic or pharmacodynamics pathway, can be called a pharmacogene. And here is another reminder of what are the pharmacokinetic pathways. So every drug, when it's administered, it will go through absorption, distribution, metabolism, and excretion. So don't put your understanding of pharmacogenomics on, don't limit it to only the metabolizing enzymes. Also, pharmacodynamic pathways are the drug targets can be ion channels, can be enzymes, can be transporters, receptors, and all of these genes that code any of these are pharmacogenes, and any variation in these that have actionable effect will be pharmacogenetic variations or pharmacogenomic variation. So talking about variation, you might be hearing a lot about single nucleotide variants. So what are single nucleotide variants? It's the predominant form of variation in the human genome, including, of course, the pharmacogenes. These are the most common type of variations that we encounter in the human genome. However, they are not the only type of variation, because there are also insertions, deletions. There are structural variations like a duplication. Sometimes a whole gene is, and more like 2 or 3 copies or even more of a gene like CYP2D6 can be present in a person and maybe in one of us. At the other end, there are sometimes some people who are having a complete gene deletion, and some of us maybe now, and without showing any phenotype or any effect, are lacking a whole gene like CYP2D6. Also, there are some other variations that are less common in pharmacogenes, like inversions, insertions, and translocations. So these are the general pharmacogenetic variation, but we call it some specific variants as actionable pharmacogenetic variants. So when you hear this, you have to know, you might be asking, what does the actionable means? So actionable here in this context means that any genetic variation that exerts a discernible influence on drug safety or efficacy in humans that is supported by clinical evidence. So you can't call something that is not supported by enough clinical evidence an actionable pharmacogenetic variant, because you can't act upon this. If there is a standard clinical or an evident clinical study supporting that this genetic variant is associated with safety of this drug and it needs to reduce the drug dose, at this case, you can call this genetic variant as an actionable genetic variant. So you will hear a lot about haplotypes and diplotypes. So what do we mean by haplotype and diplotype? A haplotype is a set of alleles, so different forms of a gene, but a set of them that are close together in a chromosome, the same chromosome, and are inherited together as a unit. So let's see at this figure, we will see here that the AGT at this point, this SNP, this variant, while some people will carry AGT together, so others will carry GTA, others will carry AGA. So are three variants that are always inherited together, and mostly these haplotypes differ between populations and ethnic groups. And as we are all having two copies of each gene, one inherited from our father and the other is inherited from our mothers. So in this case, the two copies of a haplotype are called diplotype. So indeed, you are dealing or reading more papers in pharmacogenomics, or you're attending pharmacogenomics webinar, you must have heard the word star allele. So what does this star allele where does this star allele come from? It is a standardized system for nomenclature distinctly created for pharmacogenomic alleles. So it is the way that pharmacogenomic alleles are called, or the pharmacogenomic haplotypes are named. So you won't hear this nomenclature outside the pharmacogenetic field. So also, you will need to understand that these genotypes and these different alleles are reflected as different phenotypes. So what are the phenotypes? In this case, this applies mainly in the status. So it applies to the pharmacogenes active in metabolizing drugs. So we will see that us as individuals can be for a specific drug and a specific enzyme, you will either be poor metabolizers, intermediate metabolizers, normal metabolizers, rapid metabolizers, and ultra rapid metabolizers. So how can we link between these concepts and the concepts before about the alleles, haplotypes, and the star alleles? Let's take an example like CYP2C19. CYP2C19 has star allele. Star allele 1 usually is the extensive metabolizer or the normal metabolizer status. So those who carry the star 1 allele or star 1 diplotype will be normal metabolizers, while star 17 has an increased activity. So those who carry star 1 star 17 will be rapid metabolizer. But those who carry two copies of star 17 will be ultra rapid metabolizers. At the other end of the range, we will find those who carry an inactive allele like star 2. So star 1 star 2 or star 2 star 17 will be intermediate metabolizer, and those who carry two inactive alleles like star 2 star 2 will be poor metabolizers. So let's take an example of how gene-drug interaction affect the drug response. And one very common example is codeine. Codeine is a prodrug, so it's an inactive drug until it gets activated mainly by CYP2D6, which converted to the more powerful or potential, more potent analgesic, which is morphine. So for those who carry more than one copy of CYP2D6, they will have a higher conversion of codeine to morphine. So they will have high morphine concentration and they will be at risk of toxicity. While those who carry the normal function, they will get the expected morphine concentration. In contrast, those who have one lost copy of CYP2D6 or one inactive allele of CYP2D6, like CYP2D6 star 40, they will have lower morphine concentration. And those who have a complete deletion of CYP2D6, or what is known as CYP2D6 star 5, they will have no morphine. So they will be taking codeine without getting the potential or the needed efficacy of analgesia from it. Another example is the other way around. What if we have an active drug like mercaptopurine or azathioprine? So these want to be used for in oncology for their cytotoxic effect and as immunosuppressants. So let's take this example. 6-mercaptopurine is commonly used for acute lymphoblastic leukemia, and for these patients, after the drug gives or exerts its effect, it should be metabolized and excreted from the body. And the main metabolizing enzyme in this case to deactivate the active drug is TPMT. So what if these patients have a decreased function TPMT? The drug will be available in their body in its active form for a longer time. So they will be at risk of hematological toxicity. And what about any function of TPMT? So in this case, they will be at very high risk of hematological toxicity, and sometimes it's unfortunately a fatal. So in this case, this pediatric ALL patient is not at risk of the disease, but at risk of due to or mortalities due to side effect of their own chemotherapy. So are pharmacogenomic tests ordered? Unfortunately, most commonly, pharmacogenomic tests are mainly ordered reactive. When a drug with a non-genetic interaction is to be prescribed or has already done or caused a side effect, and we want to, or the clinician seeks to find an answer of the reason of such a side effect. While indeed the optimal thing to do is to do it preemptively. When an individual gets tested for a set of genes or a PGX panel, not to interact with common drugs, so they can have their pharmacogenomics profile ready to use whenever a prescription of any of these drugs in the future. And indeed, this approach is much more cost-effective compared to the previous one. So now I move into the practical part of this talk, and I will be sharing some of the resources you will need for practicing pharmacogenomics. But before that, I would like to take a break and check the questions. Is it okay, Destiny, before moving into the resources?
Yeah, absolutely. Absolutely. That would be fantastic.
Okay.
Okay.
You see my screen?
Yes. Okay, it's gone off now.
So I want to check the questions. Did we receive any questions?
Okay. There's none in the chat box.
Okay. So
There's
if you
none.
have any questions before I start with the practical part. Okay. All is clear until now?
I think I see some hands. I see some hands, except these ones are not for questions. Okay, I think there's a question now. Um,
So
Someone
I'll
is
take two
asking.
questions. Yeah.
Okay, fantastic. Okay, from Ayman Begum, what if we go for genotype and there is no response of the drug? What will we do? What if we go for genotype and there is no response of the drug? What will we do? That's a question from Ayman Begum.
So, Ayman, do you mean that if we get a genotype and this is normal and still we have no response to the drug? Is it what you are asking? So in this case, yeah, okay. So in this case, what we know about pharmacogenetic variation among all these years is still we are just scratching the surface, and we are just now trying to connect all this information and make it more supporting to understand all the gene drug interactions, because these genes are usually very polymorphic, so we are having a lot of variations, and not all variations have been studied very well and supportable enough evidence to be included in the main pharmacogenetic databases. So I hope I answered your question, and you will get to know more about the types of pharmacogenetic variations and the evidence supporting them in the second part of my talk. Any other question? Okay. So can we find association of single gene with a combination therapy? Yes, of course. There are now like softwares that help you in entering all the medications that you are or that your patient is taking. So you include drug-drug interaction beside gene-drug interactions, and so you enter the genetic profile, you enter all the drugs that the patient is taking, and you get a report with a full description of what are what is the dosing changes that you can apply, what are the choices that are more favorable than the others. So it's now doable and it's becoming more easier with the advent of AI. So I move now into my second part, if you allow me, and please keep your questions until the end. But I think it's time to start something in practical, so you get to know to have touch into these like theoretical concepts. Okay.
Amazing.
Okay. So I'll share again my screen. Okay. So I move now into the resources you will need for pharmacogenomics. Okay, you see my screen, right? Okay.
Yes.
So the
Yes,
first,
we can
yeah,
see it
thank you.
now.
Thank you, Destiny. So first, let's start with something that we are all familiar with, which is the FDA. FDA, we know it's the Food Drug Administration, the US-based Food Drug Administration, but it is like globally known source for drug information. And FDA has started creating its tables of pharmacogenomic associations a long time ago. And if you go into the FDA tables of pharmacogenetic association, you will see a table like this. And this is very like concise information about specific gene with drug interaction. For example, let's read the first one, abacavir. For abacavir, you will interact with HLA-B gene, and the specific allele is those who carry the star 57 or one allele. Okay, so those who carry this allele have a higher adverse drug reactions risk, specifically hypersensitivity reaction. So the recommendation is not to use abacavir for these patients. So it's very concise, only one or two alleles that are identified, or only like for CYP2D6 with atomoxetin, only poor metabolizers without you details on what do they mean with metabolizers. And sorry, someone has turned their mic on, I think mistakenly. Okay, so atomoxetin for with CYP2D6, as you can see, it's only for a recommendation for poor metabolizers. However, there's no identification of who are the poor metabolizers, what are the star alleles who are considered as poor metabolizers. So let's move into the other resource. The other resource is CPIC. CPIC stands for Clinical Pharmacogenomics Implementation Consortium. And it's one of the consortium, one and the most well-known consortia developed to translate pharmacogenomic research findings into clinical guidelines. So by approaching the CPIC guidelines, you can get the needed help to understand how available if you have genetic test result, how they should be used to optimize drug therapy. So, for example, this is what you see if you enter the CPIC website. And why don't we do this together and go to the CPIC website? Can you see now you still see my screen?
Yes, I can still see your screen.
Yeah, so the screen is showing the CPIC website.
Yes, ma'am.
Okay, great. So thank you for answering. So the CPIC guidelines, you can see here, there's the guidelines, you can see the gene drugs, the alleles, the publications of CPIC. And so you can directly go to a specific guideline if you are interested. Let's take an example with CYP2C19 and proton pump inhibitors. And then you go here and you have to go into the publication and navigate through the publication, and either you read it or you go directly into the tables, which say that CYP2C19 ultra-rapid metabolizers should increase their starting dose by 100% for those who are taking or plan to take lansoprazole, pantoprazole, texoprazole, okay? So it is clear, but still we don't find you need to go and navigate into the website and then inside the PDF and go into the table until you reach the information that you need. So what other options we do have? It's very simple, and you will see directly the information needed, but it needs a little bit of navigation. So what other options we have? We have PharmJKB. So PharmJKB, I think, is the right place for you to get the faster and the most comprehensive information you need for gene-drug interactions. Why? Because it curates gene-drug information from different resources, including FDA, including CPIC, and other consortia like DPWG, which is the Dutch Pharmacogenomics Working Group, the most active consortia in Europe, and the Canadian, the French, the Japanese. All these information are created in the same place, beside information from PharmVar, and which curates the star alleles, and unupdated, all updated in the database of pharmacogenomic studies are all included in the same website. So let's, I can go through pharmacogenomics PharmJKB website, but I have already uploaded some of the screenshots, so you make this easier for you. Like, for example, this is how the website looks when you open the page. And you can see here, you can enter whatever drug you need. Let's say you are looking for a specific information about pharmacogenetic interactions for warfarin. So you just enter warfarin and you press warfarin, and this is what you get as a cover page. You will see here all these different sub pages. So you have the first one is the overview. The second one is prescribing info. So what does prescribing info know? This is the most important thing if you need the answer for your question directly. If you have what are the main how this genetic variant affect warfarin, for example. So this includes prescribing info to find the published pharmacogenomic guided guidelines. So it curates all the guidelines for this drug that are already published. So including CIPIC, including DPWG, any American Heart Association, if they have any pharmacogenetic interaction that is related to this drug, you will find them all in this tab. The second tab that you need is to go to drug label annotations. In this tab, you will find the annotations that you will find in the drug labels as released by the FDA or the EMA, the European Medicinal Administration. So this is also a very important resource for pharmacists. The next tab is clinical annotations. And this is, if you are doing research, this is the tab that you will start with. If you are not practicing, so if you are practicing in the pharmacy or as a clinical pharmacist, or you are a doctor, a clinician, you will go to directly into prescribing info. But if you are like me in the pharmacogenomic research, you will be living in the clinical annotations tab. Here you will find information about all the variant drug pairs, including those that didn't reach into the level of guidelines. So this gets me back to the question I received before. You will find any all the studies or all the gene drug interactions that have been gotten or delivered from the research in this place, all the clinical annotations. But these have different levels. And as you can see here, there are some variants 1A and 1B, 2A, many variants in level 3, and a little bit of variants, some variants in level 4. So what does that mean? And this is a classification designated or put in by PharmJKB. So level 1 includes 1A includes any variant drug combinations with variant-specific prescribing guidelines. But level 1B describes a variant drug combinations with a very high level of evidence, but still no guidelines have been published for this association. For level 2A, these are variants in important pharmacogenes with moderate level of evidence for causation of drug response. Level 2B, these are variants in pharmacogenes, not very important pharmacogenes, so they are not very well studied, but they have at the same time moderate evidence of causation. Level 3 includes variants with low level of evidence or sometimes some conflicting results. So a study have shown that this variant causes this specific effect. Another study showed the opposite, that either it doesn't have any effect or it has the opposite effect, like instead of increases, it decreases the AUC of a specific drug, for example. In level 4, the evidence doesn't support an association between variants and the drug phenotype. So in this case, if you find a variant in level 4, you are free to believe that this is not the variant you should focus on, and you should look at another variant in the same gene if you are still, if you think or there are evidence that this gene is the causative of what you have seeing as a phenotype for this drug. So what is the value of pharmacogenomic testing? So after this information, okay, you know now what is pharmacogenetics and why we do pharmacogenetic testing, or what not why. How can we do pharmacogenetic testing? What we are testing? What are the resources to, if you received a pharmacogenetic test, how to understand? But what is this, the value of all of this? Why are we talking about pharmacogenetic testing? So this figure like summarizes the main findings of the value of pharmacogenetic testing from the perspective of a physician and from a perspective of a patient. It was found that pharmacogenetic testing can reduce adverse drug reactions by between 20 to 30% of all specifically medications with that have drug. Of course, not all medications have known or approved or proved genetic effect or genetic associations, but for those, you can reduce the adverse drug reactions by up to 30%. Also, up to 99%, if more than 90, not more than 99%. So from the audience, of us, or if not all of us, have at least one actionable genetic variant that predisposes us to increased drug metabolism risk or maybe irresponse to a specific drug. So by doing pharmacogenetic testing, 7.6% improvement has been reported in medication adherence, because why patients avoid following or being adherent to a medication, either because they don't find any change in the symptoms, so they are not responding to it, or because they're suffering some side effects. So if we predict these before and give the patient the right drug, we are in this way increasing their adherence to medication. Also, for the patient, they will be saving money on medications because they are not going to try medication or a drug for 3 or 4 months and then they don't get any benefit of it. So just wasting money. And it will reduce the medical trial, which every one of us hates it, hates feeling like a rat and experimenting on. So what are the leading pharmacogenomic clinical applications, or what are the fields that benefit most from pharmacogenetic testing? Mainly for now, we know that oncology is at the forefront for pharmacogenetic guided therapies because they improve the safety and outcomes and save money. And why oncology precisely? Because most chemotherapeutics and drugs used in cancer have very severe adverse events, have very narrow therapeutic indices. So if we reach into the conclusion that this patient cannot tolerate this drug and avoid it from the start, we can save lives in this. So oncology is one of the main areas of pharmacogenetics applications. Also, the same applies to psychiatry, to behavioral health, psychiatry, because in psychiatry, the medications usually have the prediction of response is very difficult, and PGX-guided treatment help patients experience greater improvement in depression, specifically in depression. It is the most commonly studied pharmacogenetic application in the area of psychiatry. Also, one of the main applications of pharmacogenomics is in cardiovascular diseases, where guided doses of warfarin was proved cost-effective and reduced the side effects of warfarin, which is mainly hospitalization and that are the main cause or the second main cause of hospitalization, indeed. Finally, we can see that pharmacogenetics has an important application in pain management because testing specific variants can reduce the opioid addiction and save up to $14,000 in a study based in the United States per patient each year in addiction treatment. So these figures tell about what's the importance of pharmacogenetic testing, but I'm trying today to get you some taste of pharmacogenetic testing understanding. So let's practice together. Now I will introduce to you the scenario of Mr. John Smith, who is 56 years old, who is suffering from major depressive disorder, and medical history has anxiety, mild hypertension. So this patient has not responded well to his initial antidepressant therapy, which was escitalopram, which resulted in suboptimal outcomes and undesirable side effects. So his psychiatrist has now ordered pharmacogenetic tests to guide the selection and dosing of a new antidepressants. And he meets you at this point. So what's the question? Pharmacogenetic test results have
You don't
now
understand.
narrowly
You lose money. You lose
and
your business. You lose customer. It's
sorry,
affecting the business, the establishment. But not
someone
you
has
as a
their
person.
mind. Okay, so pharmacogenetic tests show that Mr. John Smith has CYP2C19 star 2 star 2 and CYP2D6 star 4 star 4. So the question for you now, can you explain Mr. Smith's suboptimal response? Is citalopram? This is the first question. And the second question, his doctor is planning to switch him to fluoxetine. Is it a good option or not? So these are my questions to you. And now I'll go answer your questions. Please, when you have the answer for these, write them down on the chat box and we will get back into correcting the answers, your answers. Okay? So now write down these the test results: CYP2C19 star 2 star 2, CYP2D6 star 4 star 4, and the medications escitalopram and fluoxetine. Okay, and okay, so I will now turn on the sharing screen and go back to the chat box to see your questions and your answers. Okay. So can you show us the question? Okay, I have stopped sharing the screen, but the question is, the patient was taking escitalopram, okay, and he is having CYP2C19 star 2 star 2, CYP2D6 star 4 star 4. So was this escitalopram a good option? Why he didn't respond to it? And the other question is fluoxetine suitable or not? Okay, so until you answer these questions, I'll check what the answers, the questions that have been raised before. Can you kindly share with us the lecture notes? Yes, I'll be happy to give you a PDF file that I will share it with Destiny, and he will maybe share it with the attendees. What if we go to the end? This is one of those answers. Thank you, Dr. Muhammad Baraka, for the compliment. Best book for pharmacogenomics study and clinical applications. So if you are looking for a book, you are maybe looking for something like basic information, because pharmacogenetic field is very evolving and developing. So I suggest you follow with more the recent journals and find out what are the most recent findings. So keep an eye on pharmacogenomics on the PharmJKB. They also have a very useful link, which is called the Pharmacogenomics Education. And through this, they have multiple links that can lead you to different resources and education of pharmacogenomics. And so the slides, as I've told you, I will share them with Destiny. And what are the steps followed for a fresh graduate who wants to pursue this field? So a fresh graduate from pharmacy, it differs between country and other, but there are currently multiple pharmacogenetic licensing bodies and trainings, either through the associations of pharmacist associations, and but the licensing is different, and the guidelines are different. So I'm really not aware of how this works in your country, but for sure, there are multiple resources and multiple licensing bodies that also you can find them in PharmGKB. You can find the links to the to get licensing and training in pharmacogenetics. What is the new advanced pharmacogenomics? They are numerous and ever evolving. It's an ever evolving field, and especially now with the advent of AI and the introduction of AI into pharmacogenetic variant interpretation and understanding the gene-drug interactions, it's like evolving like never. So it's every day there's something new. There are new information. There are multiple articles, and the main thing that is now under focus is understanding how can we or finding out how we can find the gene-drug interactions in a faster way, to prove the associations in a more faster and more confident way, so we can act upon them and move these variants from level 3 into level 1A, where you get guidelines for each variant in the found in the genome, especially with the advent of next generation sequencing and all these parallel sequencing techniques. We are like identifying thousands and millions of variants without being able to verify their interaction or their effect on drug response. So this is the thing that is facing us every day. So should pharmacogenomic testing be done once or per drug prescription? Thank you for this question, Fatima. Very important question. So our genome is stable from the day we are not born, we are conceived, because our genome is inherited from our parents. So this, so whenever at any point of your life you get tested and you get your pharmacogenetic profile, it will stay same for the whole of your life. The point is that the understanding of the effect of the genetic findings from your profile will be changing, because with more evidence coming out, you will get to know that variant that was identified or was given the label of a variant with unknown significance, or VUS, it will be at one point of non-significant or non to be significant and affecting a drug. So no, it's that test will be needed once in your life, but the results or the interpretation of results will change as the science will be evolving. But for now, as we have guidelines for a limited amount of genes and drugs that are currently in use, so it will be useful, and you can't be that even if you test like the set of genes and gene drug interactions that are already proved. So this is very useful for you at any time of your life. When you need the specific drug, you will get back the result and see, okay, I can't tolerate this drug, or it's better to choose this rather than that, and so on. I'm sorry, so I think some people have lost my slides through we're not seeing. That's the thing that I was not able to read the comments during the presentation. So I'm sorry if you didn't see my slides. So Ayman is answering the question. So escitalopram is not a good choice, as Ayman is telling us, because he is a poor metabolizer for this drug, and yes, switch to another drug like fluoxetine. Okay, thank you, Ayman. We will check if your answer is correct. Escitalopram is poor metabolizer. Murdo also said so. No, if he unresponsive, change to another drug. Okay, Nusayba, this is a good need to understand why he was unresponsive to escitalopram. Prescribing another drug, Chindo is saying prescribing another drug is better since his response to the initial is below expected. It's also important that his response to the new medication is observed and evaluated. Yes, this is true, but we have now a genetic test between our hands, and we need to understand it. So we need to explain why he doesn't respond to the medication. Shireen also said that he has less metabolism of the drugs. That's correct. How to get interpretation of PGX test results? So as I told you, to get an interpretation, Hariharans, thank you for your question. If you need an interpretation, you can use always Pharmacogenomics. You can enter the medication and check the drug. Now I will, after finish reading the questions, I'll do this in front of you and show you how this is done on the website. Please, can I ask about interpretation of pharmacogenomic results? Okay, sure, I will do. Fluoxetine is also metabolized by CYP2D6. Okay, thank you, Shahir, for this information, and we will check it now in Pharmacogenomics. Fluoxetine is good option. His body doesn't respond because of poor metabolism. Thank you, Amara. Can switch over to other drug, fluoxetine. So most of you say that we can, the patient can be switched into fluoxetine because he has a poor metabolism of escitalopram. We will be checking guidelines, and if fluoxetine also have the same metabolizer enzyme as escitalopram, then changing the drug to fluoxetine will be of no use because it will also have the same effect. Right. Vaishnavi Budawala. That's correct. That's logical. So what did you see? Did you check and you find that fluoxetine also is affected by the same enzyme? And which one, CYP2C19 or CYP2D6? Fluoxetine also gets metabolized by CYP2D6. Since he is an ultra-rapid metabolizer, it's best to just increase the dose of his medication. This is the point of view of same Mercy. Thank you, Mercy. The result is kind of affirming of MIMAM because if the patient is giving a mild response to the drug, it implies that he is a fast metabolizer. But then STAR2 result means that he's a poor metabolizer. Okay, so you are a bit confused. We will explain now. So not responding, both genes indicate a poor metabolizer. Okay, so without further confusing you more, I'll get back into Pharmacogenomics, okay, and we'll get the results of my question. Okay, sounds good. So now I'm sharing the screen again. Okay. So here's Pharmacogenomics, and here's my question. The question was that he was taking escitalopram. Okay. So here what I do, if I have to answer this question. Okay, 1 second. Sorry, guys. I don't know why the... Okay. Okay. So for me, I'll write escitalopram here. Okay, and I don't have the patience to complete writing it. Okay, so this is not the one. Escitalopram. Okay. So this is escitalopram. I'll go into prescribing info. Okay. Because I want the answer very fast and I don't want to go through all the evidence. I just need the prescription. Is it correct or not? Let's assume that I'm at the pharmacy and I'm on the phone with the doctor and I have to answer this directly. Okay, so it's very easy here. If you go, did you see where I went? I went to prescribing info and then I selected CIPIC. And here I got star 2 as a result. Okay, so CYP2C19, poor metabolizer. And as you can see, escitalopram is only affected by CYP2C19. I have the results for CYP2C19 and CYP2D6, but I'm using only the results for CYP2C19 because this is what is available for prescription. Okay, and I have chosen the alleles that I have the results I have, star 2. So directly I will get the results. This is a poor metabolizer. So the implication, reduced metabolism of citalopram and escitalopram to less active compounds when compared to CYP2C19, normal and intermediate metabolizer. And higher plasma concentrations may increase the probability of side effects. So consider a clinically appropriate antidepressant, not predominantly metabolized by CYP2C19. Okay, this is the recommendation. Why the patient didn't respond well to CYP2C19. Okay, to escitalopram. Is fluoxetine a good option? Let's check fluoxetine. Okay, so for fluoxetine, and let's go also to prescribing info, we can see here that there is CYP2D6, but there's no recommendation. There's no CYP2C19, so it doesn't interact with CYP2C19, an interaction that causes effect on prescription, but it interacts with CYP2D6. So I have results of D6. Okay. And simply, there's no recommendation. Although it interacts with CYP2D6, but the evidence is not strong enough to make any changes into prescriptions for fluoxetine for those who we know their CYP2 phenotype. So you were correct that CYP2D6 interacts with fluoxetine, but the evidence is not strong enough to make you avoid this medication, and it can be used until we see how the patient responds to it. So this is the answer of the question. Okay, I hope I answered the question clearly. So by this, I have finished my presentation. I hope you found it useful. Please, if you have any questions, don't hesitate to write down or to contact me. I left this, if you scan this QR code, you will reach into my email, my LinkedIn page, my website, and all my information. And because I believe that we cannot reach into this stage when we see the patient and he give us the DNA sequence and we give them the right medication until we collaborate and learn from each other and support each other to reach this stage where we are happy with giving our patients the right drug at the right dose, right time, and our patients are satisfied by the more precise medication. So thank you and hope you enjoyed my speak. Please, if you have any questions, just go ahead. Thank you. Thank you for all the kind words. It was amazing seeing you all and your kind interaction, and your answers were almost correct. Most of them were correct. And I hope you have learned how to use this website and all. And if you need any help, please don't hesitate to contact me or to send me and connect through LinkedIn. I'm more than happy. I'm an advocate for pharmacogenetics, and I'm happy to answer all your questions and to support you if you are interested in research in pharmacogenetics or you need any help in application or implementation of pharmacogenomics as your clinical sites. Okay, so Destiny, I think you are not with us anymore.
Ma'am, am I audible?
Yes. Yeah, go ahead.
Ma'am, how to know for which drug, like which genetic testing to be done?
Okay, so in PharmJKB also, if you go into the website and you will find all the tests that you can see, like a table that collects all the medications that have proved and actionable, because there's no point of doing a test while if you get the results, you can't do anything with it, right? So if you are asking about testing that you can act upon, you need to test for the actionable variants, and these are all curated in PharmJKB in the prescription tables.
Okay, thank you.
You're more than welcome. Thank you for your question.
Am I audible, ma'am?
Yeah, go ahead, Serti.
I want to ask, what are the risks and challenges in implementing pharmacogenomics?
Okay, great. Thank you. This is a very important question. And actually, at the beginning, I was planning to put this, but then I thought, okay, this is the first session in a series. I should not start with with the challenging things. So I removed this part from my talk. So there are multiple challenges. First of all, most of the studies in pharmacogenomics are conducted in European ethnicities, as all genetic studies, and as most of the clinical research, unfortunately. So we can, as populations, understudied populations and underrepresented populations in Asia, and also in the Far East, and in Africa, and the Middle East, all of us are underrepresented populations, which we might carry pharmacogenetic variants that are prevalent among us, but they are not detected because we are not very well represented in genetic databases. So this is one of the main challenges for us in this area of the world. Another challenge is, let's say you had the setting, you have the lab that can do these tests, although it's not a complicated test. The day when COVID started, the next day, all the labs were acquiring PCRs and real-time PCRs, and they were able to do the test. So it's just the same. Pharmacogenetic variants can be tested by real-time PCR, the same tests that were applied for COVID. So let's say we have the tests available and you have the setting to do the test, but who are the practicing clinicians who understand or who take these into considerations and can understand a genetic report? So it is our responsibilities as a pharmacist and also as clinicians who are new to the field to get to understand, understand, and evaluate pharmacogenetic results and being able to act upon them. So this is a second challenge: the education of practitioners, education of students, education in pharmacy colleges and medical colleges about pharmacogenetics. This is a second challenge. One of the main and unfortunate challenges is the cost of pharmacogenetic testing, which is mostly not covered by insurance. And until we reach the point that we prove that pharmacogenetic testing is cost effective because it reduces the cost of adverse effects, it reduces the cost of medicines that are not effective, until we reach that point, we have to be patient and do more research to prove to insurance companies that this is cost effective and you have to pay for it better than paying for a drug that will not work or that will cause hospitalization, that will cost more and more on the insurance company. So these are, in my opinion, the main challenges. There are a lot of challenges. Otherwise, we could see each of one of us would have their pharmacogenetic profile, their iPhone, and go and or their phones and go check these before a medicine. But this is not the truth. And these are the three main issues and obstacles facing pharmacogenetic implementation from my point of view.
Okay, thank you, Ma. How are you?
I'm good. How are you, Haruna?
I'm fine, thank you. So I have a question concerning this pharmacogenetics. What are the role of the regulators in pharmacogenetics?
Yeah, great questions, Haruna. Actually, the regulators, the thing is, we are like between, we are under the governance of regulators that need to see proof of the effectiveness and cost effectiveness and the safety of these practices before being like making them as mainstream. And this is actually reasonable. But for us as researchers, we strive to find like to find collect patients and include also to find to like reach into the statistical significance. So we have different point of view of the same things. We all start to or try to reach to the best treatment and best healthcare possible, but we have different priorities. So the role of regulators is to understand the advances, and the role of us as researchers is to also provide the needed evidence to convince the regulators in making these as main practices in medicine and move from one size fits all into the precision medicine practice. So it's both of us should be involved and should be collaborating in order to make this a truth rather than theoretical concepts only.
Okay, thank you very much for
You're
that answer.
welcome, Haruna. Thank you.
Okay,
Thank you for your
thank
question.
you.
Any more questions? Thank you all, actually. I have to thank you because of your interest. Yes, please go ahead.
Well, what are the best study options in pharmacogenomics, ma'am?
What
Career
are
options. Best
career
study options.
study options? So how to study to get a career in pharmacogenomics? This is
Yes,
what
ma'am.
you. Yeah, so there are many postgraduate programs now established for precision medicine and pharmacogenomics. So any of these will help you starting a career in pharmacogenomics. And of course, if you want to make it, we are trying to make it as part of every pharmacist and every practitioner understanding pharmacogenomics, not making it like for a small group of experts. So the career starts with getting the knowledge, getting the education from the different bodies that are providing training in pharmacogenomics. And then if you want to go into the research, you have to go for into the line of postgraduate studies. And there are multiple programs now providing degrees in pharmacogenomics and in precision medicine. Or if you want to make it as part of your practice, you should be working on yourself and figure out the licensing options in your country.
To us, ma'am.
Assalamu alaikum, madam.
Assalamu wa rahmatullah.
This is Abdul Rauf from Pakistan.
Welcome, Abdul Rauf.
Thank you, ma'am. You have delivered in a very impressive way. Thank you so much for that. Ma'am, my question is that as pharmacogenomics is a really new area, but the main challenge is that how this gap will be established between the clinician and the researcher and the pharmacist.
Yeah, that's true. I believe that this is where the regulator's role comes on. they have to put ways for who can order the test, who will interpret the test, who will deliver the test results and consult the patients regarding the results, and how these can be all coordinated together. And I believe that the pharmacists should play the major role in this, in harmonizing between the different stakeholders in this process. So we have the lab, we have the pharmacy, we have the clinical pharmacist, we have the doctor, the clinician who will by the end change the dose or change the medication. So all needs on. Also, we have the payer, who will be the patient or the insurance company. So this needs regulators to arrange this, and how the connection between these different stakeholders.
Thank you, ma'am. Exactly. Resources and these all are big challenges for this area.
That's true. But the thing is, as I mentioned, it's not that complicated. It can be done by real-time PCR, just for the variants that have already evidence on it, that have guidelines, and we can start from there. And later on, all the pharmacogenomic implementation programs started with only one gene, and then they have increased one by one. So it's doable. It's not that hard. So I can see that. Thank you, Abdurraouf. I can see that Daniel is have been raising their hand. Daniel.
Madam, you are audible?
I can hear you. Who is talking, Zain?
Yes, sir. I am Dr. Zainul Hassan.
Welcome.
And the founder and patron-in-chief, Pharmacy Graduate Association, Pakistan.
Welcome, Dr. Zain.
So,
thank you for
your presentation was very nice, comprehensive, and I listened all the points which you discuss regarding the pharmacogenomics. My question is, in Pakistan, we are doing internship program of pharmacy practice all over the country. And the most largest organization in Pakistan to improve the pharmacy practice. But unfortunately, here in Pakistan, the pharmacogenomics concept is not clear so far. And we are trying to improve this situation. But the main thing is the regulatory body is not so much interested to improve this type of therapy, which is almost growing all over the world.
Yeah,
but I want to know that how we can improve pharmacogenomic therapy in poor countries, and what are the guidelines of WHO in this regard? Please elaborate.
Thank you, Dr. Zain. Thank you for your attendance, for your kind words about my presentation, and it's my pleasure to present and to have you and all the audience. So indeed, this is a very critical point, and this is a thing that I'm always repeating and I focus on, that the situation in developing countries is much more challenging for pharmacogenetic testing. And this is understood because it is challenging in the United States. So what about the challenges in our country? Because there is resistance from doctors to adopt. There's resistance from insurance companies. There's resistance from to change the practices. So it is normal, but everything faces at its beginning these challenges. For pharmacogenetics, from my point of view, I think it's even more practical and more cost effective for poor countries. To be honest, because we don't, but we have to prove this to the regulators. We have to prove the cost of side effects. We have to prove the cost of long medication taken for a long time without getting any benefit. We have to prove that this is a waste money that we can prevent by doing a simple genetic test. So the thing is, it's like a loop. We have to do research to prove this, but we cannot find budgets for this research because the regulators can't find the point of why that should they spend money on this very fancy research. So we are staying in the
Very
same
right.
loop. It will break soon because the cost of genetic testing is getting less and less. So at one point we will be there where proving and doing. We should keep working on proving this and doing more cost effectiveness studies. Besides proving the associations of pharmacogenetics testing and all these concepts, we have to focus on the thing that our regulators focus more on, which is does this deserve the money that will be costing or not? So unfortunately, we have to work on all of this together, and otherwise we will keep talking about it as something theoretical rather than something touching the lives of each one of us.
Well, thank you. Dr. Liaquat Rada is my junior fellow, and we were giving training in Pakistan before few years, and he always managed these types of informative webinars, and we also conduct a large number of webinars on different topics in Pakistan. Even in last year, it was a webinar on pharmacogenomics, which lectured by
education is much needed, actually.
Professor Dr. Liaquat Rada is the key speaker in all those webinars. So I am very delighted that you cover all the areas of pharmacogenomics, and it will be very informative webinar for all the listeners. And I hope that you will continue other webinars on different topics, inshallah.
Hopefully. Thank you. Thank you. This means a lot to me. Thank you, Dr. Zain.
Welcome. Welcome.
Daniel, you have raised your hand a while ago. Do you want to open your mic and talk? Your mic is turned off.
Good evening, ma'am.
Hi. Good evening.
Am I audible, ma'am?
Okay, yeah, you are audible.
Ma'am, my question is on how is pharmacogenomic testing used in personalized medicine?
So, as I mentioned in my talk, pharmacogenetic testing means that you can identify, according to the genetic result, what is the best medicine out of some alternatives for this case. So in this case, if you consider the genetic results beside the other factors, this is how you reach into personalized medicine. You can reach into the right drug to the right patient at the right time and the right dose. If you consider the genetic test results among other factors that we are already using to choose the dose, for example, if this patient has a kidney failure, if he has any liver disease. And so if we consider also add to this the layer of genetic testing, we are moving into more personalized practice.
Thank
Thank
you,
you.
ma'am.
Thank you, Merdu, for your question. Okay.
I had another question. May I ask, ma'am?
Okay, go ahead. I'm not sure why Danielle is not opening the mic, because it was her turn so long time ago. Anyway, go ahead, Hertika.
As you are a professional in pharmacogenomics, I wanted to ask you if you have ever implemented or employed artificial intelligence in it.
Yeah, thank you for your question. Actually, this is a very hot topic right now, and we are working on doing some applications of AI and pharmacogenetics. I'm working currently on in a research in this field, and soon you will find, inshallah, you will read publications that we have reviewed all the possible applications of AI in pharmacogenetics. But moving this into practice, it will be also, I'm working on this right now. And it is a very important topic right now that will accelerate the whole findings and the application and implementation of pharmacogenetics. Thank you, Haiti.
Thank you, ma'am, for answering my questions.
You're welcome. Okay, I'm not sure where's the moderator, Mr. Destiny, because we are already over time. I'm not sure if okay.
Exactly.
Yeah. How are you? Where you are?
I'm here. I'm sorry about the break in transmission. The network on my end is a bit troublesome.
I was just worried that because we have passed already the time, so I'm not sure if it's
Exactly.
from any other time.
Exactly. Thank you so much.
We again lost your voice, Destiny. Your connection is not stable. I'm sorry. I can't hear you. I think all the audience as well.
Madam, you are listening me?
Yeah, I'm hearing you.
I am also the host of this webinar, but I was too late. So I joined and listened your presentation, and
It's my honor, Dr. Zain. Thank you.
yes.
Thank you for hosting this webinar, and thank you for all the organizers. It's an amazing series, I guess, and I hope that the next webinars will be also enjoyed by such an audience and joined by this large number of audience as well, and interacting audience. Thank you all for your questions. So I find like I think some questions.
Am I audible now?
Yeah. We are hearing you.
Oh, great. I'm so sorry about the break in transmission.
No.
Thank you so much. And then thank you so much, Dr. Zain. Thank you so much, the founder and
Welcome.
patron of PGA. We're really grateful for the opportunity to collaborate. We've come to the end of today's session. I'm really excited about that, and I know that you are excited too. I just want to give us some few announcements before we finally leave the room. First of all, our next session for the series is going to be happening on the 15th. That's not tomorrow. On the 15th of February 2025. That's a day after tomorrow. And the section is going to be on practical case pharmacogenomic studies involving secondary findings. And we have another amazing speaker who will be coming to help us do justice to that. The time, of course, will be shared on the WhatsApp link, on the WhatsApp waiting room, so that we get to know when the session will be. And the feedback form has been shared in the chat. Please do ensure that you help us get your feedback of what the section is about, so we can improve subsequent sessions and get to do more. Thank you so much once again. And just to add again, I did mention at the start of the webinar that to qualify for getting certificates of participation at the end of the series, one would have to meet at least 70% of attendance. So do ensure that each time you come around, you take attendance and you do that. And for today's session, our attendance would be with the feedback form. It will be with the feedback form. Sorry about whatever.
Thank you very much, all the participants, especially Madam Zeni from Pharmacy Graduate Association, PGA. It is wonderful seminar, or we can say a knowledgeful webinar on the advanced topic of pharmacogenomics with the latest technological information and implementation for the safety of the patient, and also the targeted therapy for needy patients like oncology, psychiatry, and cardiology. And madam, your services are wonderful, and this session is very knowledgeful for all of us.
Thank you. Thank you. Thank you all. Have a great
Thank
evening.
you so much. Thank you so much. All right.
Bye.
Good night, everyone. Thank you so much. Thank you so much.
Thanks.